you so much for the invitation for this elegant meeting. Actually, I wanted to start my presentation just for a comment for the last session is a lot of our surgical procedure and interventional procedures are palliation for a disease which is running in a speed that is varies. Sometimes the muscle, the vessel, the valves, the speed of the problem is very fast rather than the technology or the surgery or the medication itself. Today I wish to have some discussion about the paravalvular leak problem. We had a lady, 54 years old, and she had a CABG with 2 grafts and mitral valve mechanical replacement. This lady was presented 2 years later with severe right ventricular failure, pulmonary hypertension, and actually with another problem, which is hemolysis. If we look carefully to this echocardiography, the imaging is the stand alone, what we call diagnostic tool that to pick up the problem, to evaluate the problem, and to direct for the next step. We can see a large defect with a severe paravalvular leak. We can see it's in the medial position, which is usually the main problem. To familiarize ourselves with usually the problem of the paravalvular leak, we look to the surgical view. We look to the in-fus view. We have toward the septum is the medial, toward the aorta is anterior. So usually we have the anterior, medial, posterior, and lateral. When we are talking about the medial, anteromedial, posteromedial, this usually is difficult to tackle in most of the cases. And unfortunately, this is a very common. Localization and defining the defect is a paramount of the echo lab before the procedure. Sometimes we add a CT. Here we can see the CT imaging, which is not usually the case for the mitral, to see the defect, the size, the orientation, and the relation of the posterior wall to the possibility of entrapment of the disc during the closure. Now, if we look carefully, briefly for this patient, she has a single medial large defect. It's around 12 to 13 millimeter. What is next? Now, if we are going to look carefully to send this lady to surgery or to the interventional lab. So if we look carefully to the all comers of mitral valve replacement, we have 74% of these patients who present with paravalvular leak, they present in the first year. And 26% of these patients can present later throughout their life. The worst scenario of this patient is the people coming with an annular calcification or post-infective endocarditis or a persistent inflammatory process, because usually it's an ongoing disease. And if we look carefully, what is with against, when we have a patient with valve mechanically unstable and or infective endocarditis is still active, there is no role for percutaneous option. It's only a surgical issue. But patient with heart failure, hemolytic anemia with a stable valve with no evidence of infection, usually they can get a benefit from the percutaneous closure. If we would like to see a patient to put the plan, we need to consider the symptoms, the indication to do either the hemolysis or worsening of the heart failure. And we should have the echo or the hemodynamic proof of the paravalvular leak. And then to understand with the 2D and the 3D what we call evaluation, proper evaluation and assessment of the problem, sometimes the CT can add. To execute this, we need to plan it very carefully to know the access, how to cross, how to support, which device to use, and also to identify what we call the endpoint of the therapy. The access to the paravalvular mitral is either transseptal or transseptal through the superior vena cava for some of the medial defects, or retroaortic through the aortic valve if we have a native or mechanical, or per-apical or transapical. With the red lines, which is the medial, anterior, posterior, usually it is preferred to go apical access because it is much safer. For this lady, we elected to do the patient a percutaneous access. We tried to save her apical access. We started with the retrograde access from the aorta. We crossed the defect, and then we went to the transseptal to snare the wire, to exteriorize the wire, and then to select the device. when we think about the device, we need to know some about these devices. We don't have exactly what we call an ideal device for this plenty of shapes, either crescent, either rounded, or big. This type of defects, we need to try to imagine which device will fit in place, adequately sizing, and it's not oversizing specifically for calcified annulus, not to create another defect. And also it should be, or most of the cases, to be a double disc devices to make sure that it will be flared around the annulus, the mitral valve annulus, and also to make sure that the stability of this device with the progression of the deterioration of the annular tissue. We have from what we call from Abbott, we have the AVB family, the ambulance vascular plugs, which is the AVB2 and AVB3. They are the best working devices. And we have from Occlutech, we have a paravalvular leak device, which is a dedicated device that it comes with almost 4 shapes, which either rectangular or a square. It is narrow waist or wide waist to try to adapt to the different varieties of the defects. The one I mostly use, which is the ambulance vascular plug 2 and 3, they are similar, but one of them is oval shaped. It can take the shape of the crescent with a bit small overhanging of the disc that it minimizes the problem of impairment of the device or the disc of the valve. When we look to our case, we elected to use the muscular VST because this defect was a big, and also there is a big space away from the leaflet to have any entrapment. So when we put the device, it was a single device rounded to the same shape of this defect without any impairment of the valve leaflets, with a good result and a good complete amelioration of the defect. And also we can see from the endpoint of our closure, we have a restoration of the normal pulmonary venous flow and the complete disappearance of the what is called the severe incompetence. When we wanted to define the success of transcatheter device closure of mitral paravalvular leak, this is a new published data from the Canadian Society of Cardiology that we should end up with a very clear endpoint. Sometimes we have patients with torrential massive MR, and it's not to put one device or 2 devices. We should have a mild or less, because this is our language, which is what is the impact of this device closure on the long term. This is any impact on the mortality? Yes, it's truly, there is a significant reduction in the long-term mortality if we end up with mild or less mitral regurgitation. Again, from this, another data from the whole registry, this is a Spanish registry, that the percutaneous paravalvular leak with a reasonable rate of procedural success and low rate of major complication, and the type of this with accumulated what we call experience of the centers and the imaging population, usually it gives us a good acute and long-term results. In conclusion, clinical assessment of patients, specifically patients are coming with tricuspid regurgitation newly developed after 10 years or 15 years of mitral valve surgery or left side surgery. We have to think about the paravalvular leak first, specifically if we have pulmonary hypertension. So the heart failure, the hemolysis, to start with excluding endocarditis is the starting point. Number 2 is a transcatheter closure. It's the preferred for the patient with heart failure or hemolysis, because when we compare the risk of surgery to compare the safety of the paravalvular leak, we have to consider the best of the patient. Majority of the cases, they need multiple devices. Combined approach, specifically for large or multi-defect, is usually the cases. We should have a good toolbox for imaging, for devices, for varieties of needed materials. My take-home message for patients with paravalvular leak closure: we should have a pre-procedural planning. Transesophageal echo is the gold standard. We would like to have it in the 2D, the 3D. Sometimes the CT is helpful. It is crucial for adequate device selection and determine which type of device, which size, and how to plan the procedure. During the procedural guidance, as we saw the echo for the TEER or for the mitral valve intervention, it is also very, very crucial to see, are you crossing from the valve, from the leaflet, from the defect through the valve itself, affecting one of the leaflets, adequately sealing the defect, adequately touching the endpoint that we are aiming to. Fluoroscopic guiding of the leaflet motion is another priceless way of assessment for safety of the patients, not to, by the end of the procedure, that unfortunately you impaired one of the two leaflets, and so it ended up with another major complication. The post-procedure assessment, again, is 2D and 3D assessment in combination to reassess for the proper device position, residual lesions, and touching again the endpoint of the procedure. Thank you very much.
Thank you, Dr. Reda. Amazing.